It's an honor to be here, Steve Jaffe. On a personal note, I come through child psychiatry and to work with addiction. 1985, I'm running an adolescent program. Half my kids are using drugs and alcohol. I don't know anything about this. Never learned any of this at Mass Mental Health in the 60s with Dr. DuPont was there also. Nobody ever talked about addiction. What I did is I hired a wonderful recovering counselor. He and I ran a group together 5 days a week for 4 years, and everything that I know really came through that type of frontline clinical experience. Essential ingredients for an adolescent program. I've ran adolescent programs for 25 years, and I still consult to three programs that I'll talk about. The components are you need a developmental approach for teenagers, complete assessment to determine the level of treatment, the specific treatment modalities, quality of the staff, training orientation, the issue of continuing care. 3 months of treatment doesn't give you a lot of recovery at 1 year. And then the issue and the concept of enthusiastic sobriety, and I'll talk about that type of program which I've been involved with for the past 15 years. Everybody here knows brain maturation up to age 25. Of course, males are slower than females. Myelinization, pruning. Do not mix adolescents with adults. That's fundamental if you're going to run any sort of adolescent program. The issue of within the adolescent developmental levels, early adolescents are very different than mid and later adolescents. Early adolescents are the least introspective human beings on the face of the earth. So if you try to deal with their developing internal motivation with an early adolescent, forget it. You mainly work with the parent, you structure, you do contingency management, those sorts of things. So you can't even group all adolescents together. You have to look at when their drug use started, what is their age, what is their cognitive level of development, etc. Assessment, which is so important, and we have certain structured scales, interviews that have been developed by people like Ken Winters, full psychiatric evaluation, including education and the family, determine the level of care. The big issue in what I put it here and training staff for the past 15 years is they miss benzodiazepines use, which is I teach my counselors that they must ask specifically about how often and do they use not just opiates and alcohol and cocaine and all the rest, but specifically Ativan, Klonopins, Xanibars, specifically, and teach them the issues of physical dependency and withdrawal. We've had a number of kids that before they came to us, somebody stopped their benzos or didn't ask about it. They have a seizure and they almost die. So that's a key issue that's often missed. The other issue is, and I spent half my life taking kids off medicine as they come into the enthusiastic sobriety program that I work with. You go to a child, adolescent, or adult psychiatrist, the teenager's a little depressed, anxious, so you give him, he must be bipolar. Certainly every meth and cocaine addict looks bipolar. It is an entity. The medicine has to come off, of course, in a considered fashion. But for those that are truly bipolar, you've got to stabilize the psychiatric condition before you can get to the substance abuse. Level of care is determined, everything from early intervention, outpatient, IOP, and residential. Treatment modalities for adolescents must include the family and consider the role of peers. And here I have the Chinese menu of treatments. I just finished the third time that I've summarized the research on this in the ASAM adolescent treatment section in their textbook. The first issue is how to get them to develop some motivation for abstinence. By the way, some of the studies, if you go from 25 days a month of smoking marijuana to 14 days of smoking marijuana that may be statistically significant. For most of us in the field, it's not clinically significant, and some of our evidence-based models and things that are put forward in the field are based on that, which was already mentioned earlier today. That decrease of 20 or 30% may get your paper published. It's not significant because next month he's smoking pot 29 out of the 30 days. I have a workbook. I have 2 left that I brought with me that I'll be glad to give if anybody's interested. It's an intervention manual they fill out. They present it at a group. It's discussed and trying to develop some internal motivation. Oh, gee, or usually, oh, shit, my life is a mess. I didn't realize so many areas of my life have been messed up. And it's done in an adolescent type of fashion. Family-based therapies, multidimensional, multisystemic. These are outpatient types of therapies for substance abuse. By the way, the best data is for multidimensional, functional family therapy, and group cognitive behavioral. And it depends, I call 12-step facilitation and the use of that if you can hook the kid into it. There is a significant evidence basis for that. Whether it meets criteria or not is up for discussion. Contingency management, and most programs use a variety of all of these 12-step approaches, and I have another workbook to modify the first 5 steps for adolescents. You never use the word powerless. It's powerless over drugs and alcohol, but they see the word powerless. Forget it. I don't want this program. I'm here to gain power. The issue is, and I reinterpret it, if you get clean and sober, you have the power to have a life and do things that you want to do. And I try to put it into those frame of reference. The problems with all of these is that recovery is only a year later by most of these therapies, 30 or 40%. I remember way back years ago when one of Scott Hengler's people was presenting the results of multisystemic therapy. I invited them to do grand rounds at Emory, and I'm sitting there and seeing the data, and all of a sudden I realize, well, wait a second, 50% of the kids don't respond. When you present, it's statistically significant, but I want to know how many are in recovery. All of these whole menus, it's something like 30 to 40% at best are in recovery or minor relapses or abstinent at the end of a year. Psychopharmacology, mainly for comorbid conditions, by the way, 30-40% of the kids have ADHD, 20% of them have anxiety disorders, 30% of them depressive disorders, 20% of them have been sexually or physically abused. Training of staff. The program depends on this. If you don't have good staff, forget it. I don't care what your philosophy is, how much money you put it in. They have to be well-trained, good experience. They have to love working with teenagers. If they resent it or they're jealous of these teenagers are having all this fun and all this sex and drugs, forget it. It's not a good staff member. They have to have good boundaries. And you need some that are in recovery. Now, I happen to find, on the other is assertive aftercare. As I said, assertive continuing care. They make the responsibility for the follow-up to be on the shoulders of the professional. So that person has to either in-house or by phone follow up. That has increased the amount of teenagers in recovery. More time in treatment, the better they do. Continued individual, group, and family. And then, of course, 12-step involvement. I happen to find Dr. Gold's secret serenity prayer that Calvin describes here. I'll read it. Know what I pray for, what? The strength to change what I can, the inability to accept what I can't, and the incapacity to tell the difference. I'm sorry to share this with the group. You should lead an interesting life, which Mark certainly does. Oh, I already do. Okay, concept of enthusiastic sobriety, program I've been with for the past 15 years. The emphasis is on having fun off drugs and alcohol. It's a program of attraction. Mark sent Scott up to visit me with this. It's a unique type of program. It's the only program I know that the kids love. It is a program, it's built on all the staff are in good, stable recovery. They're 20 to 25, except for the director and me and some other people. I go every Wednesday morning and I review all the kids in the program. It's an intensive outpatient program, 4 hours a day. They're in groups. I could not spend 4 hours sitting around talking and jiving and playing games with teenagers, no less druggy teenagers. This staff can do it. The staff become models, and the staff, all of them love being clean and sober. They've been well-trained. They have solid recovery. We know them. They come out of our program. We provide something like 12 to 14 weeks of treatment, 5 days a week, 4 hours a day of IOP. They sleep at each other's houses. We have 2 evenings a week of groups, which includes the kids for up to 2 years after they're out of the intensive outpatient program. We have a parents group. The parents sponsor each other, work with each other. The key issue that is done, not only is it fun, but we provide social, fun activities that the kids love on weekends. So we give them a recovering peer group. We handpick their sponsors, which are kids in the program that have completed it and are doing well. And we form this whole environment that the biggest problem, of course, is that the teenagers go back to their using peers. You know, oh, I'm going to be the first teenager in the world that can go to a party where they're smoking pot and I won't use. And of course, they smell it. Goes right into their brain, you know, and you know, you can do all the cognitive CBT therapy about how you refuse this. I did this with took Yafra Kamener's CBT protocols, and I did it in an outpatient program, and I learned very early. I had a young man who. I taught him how to assertively refuse drugs. You say no immediately. Is time up? I didn't hear a click.
You didn't? They're amazing.
Missed it.
Hey, Garrett.
Click it. All right, let me just finish. Let me finish just this. At any rate, he went, I taught him how to say no. He went home for the weekend, smoked pot. I said, how come you did it? He said, 'cause I wanted to. So I was teaching him social skills to be a better, more high-functioning marijuana user with better social skills. I thank you.